Hello, everyone, and thank you for joining us for this webinar on wounds of wars and conflicts, a multidisciplinary approach. My name is Souha Kanj, and on behalf of the Lebanese Society of Infectious Diseases and Clinical Microbiology, I welcome you to this webinar. Please note that this is a collaboration between the Lebanese Society of Infectious Diseases and Clinical Microbiology, the Lebanese Society for Plastic Surgery, and the Lebanese Society for Dermatology. This webinar has been endorsed by the International Society of Antimicrobial Chemotherapy. My name is Souha Kanj, and I'm the president of the Lebanese Society of Infectious Diseases and Clinical Microbiology. And in this webinar, we're going to address the very important and timely topic of wounds of wars and conflicts, and how can we manage this problem in a multidisciplinary approach. And this is why we have four esteemed speakers, two microbiologists, a dermatologist, and a plastic surgeon to address this problem. And without any further delays, please allow me to tell you that we will be receiving questions during this webinar. And for that, please send your questions in the box where it says Q&A, and we'll try to address as many of these questions as possible. It's my pleasure to introduce the first speaker for this webinar, Dr. Antoine Abou Fayad. Dr. Fayad is Associate Professor of Microbiology at the Faculty of Medicine at the American University of Beirut Medical Center in Lebanon. He will be talking to us on the emergence of multidrug-resistant pathogens in wounds, the Lebanese experience. Dr. Abou Fayad, the microphone is yours.
Thank you, Dr. Kanj, for the opportunity, and thank you for allowing me to present to all of you today our experience with the emergence of multidrug-resistant pathogens during conflict. I hope you can all see my screen and you can hear me well.
Yes, we can. Thank you.
Okay, fantastic. Right, so I'm not gonna preach to the choir about antimicrobial resistance. I know you've all heard about it, you all live it, you all experience it daily, but I want you to look at AMR from a bit of a different perspective today. And just to let you know that we have a saying in Lebanon that says some problems for some people are beneficial for other people. And unfortunately, before the conflict started and before the escalation of conflict started in Lebanon, we were running a study that was helping us to look at antimicrobial resistance across the whole country under a One Health umbrella, under a true One Health umbrella. We were collecting samples from several hospitals across the country. We were collecting samples from several water, sewage stations and water sources, in addition to soil and wild animals specifically. And during this collection spree that we were on, we actually had a PhD student in the lab who was collecting samples from several hospitals in the south of the country, and specifically Labib, Hamoud, Hiram, Jabal Amil, Al-Ra'i, the Lebanese Italian hospital, in addition to two more hospitals in the south of the country, to be very specific. And if you would look at the graphs that I'm showing you, you could see that during his collection, and when you look at, and this is very specifically pre-escalation of the conflict, it's not pre-October 2023, however, it's pre-escalation of the whole conflict that took place in Lebanon. So mainly the last 2 to 3 months where escalation took place. And you could see from the type of carbapenem-resistant gram-negative bacteria that we were collecting in the hospitals, you could see that there was quite a a decent amount of Acinetobacter baumannii, 26 samples compared to, for instance, 27 Klebsiella, 36 Pseudomonas, and 37 E. coli in overall within all the samples that we were looking at. However, additionally, one more comparison that we looked at before dwelling into the molecular observations that we found was when you look at carbapenem resistance versus non-carbapenem resistance, sorry, during escalation and post-escalation, and remember that the pre-escalation was a very long period, was about 2.5 years. Hence, the number of samples are usually higher. But when you look at the during escalation, which is a very short period of time, which is about 2 to 3 months, you could see the number of samples increasing drastically over that period of time. Additionally, looking at the number of CRBs reported per hospital were also quite high during escalation. Obviously, hospitals cannot be, the data from the hospitals cannot be taken properly from everyone due to the fact that a lot of hospitals have closed during the escalation of conflict. But looking at the type of the bacteria that we were collecting, we note the very big rise in Acinetobacter baumannii during the escalation. During that period of 2 to 3 months, the number of samples exceeded any other pathogen that was observed during those hospitals, during those samples that were collected from the hospitals. Additionally, what we usually have in the country circulating is mainly what we call international clone 2 Acinetobacter baumannii, and it's mainly sequence type 2. Okay, and what does that mean? That means it's a strain that more or less dominates the country looking at all of the hospitals. Okay, it's carbapenem resistant, and it actually spreads across the whole nation. We have a very little presence of international clone 1, a little bit of international clone 6, and international clone 8. And the undetermined or the ones that have not yet been classified in international clones they form around 2%, 2 to 3%. Now, why this is important? Usually, when you have an outbreak, if you would see, let me just get my pointer up. If you would see over here on the screen, this is an example of an outbreak that actually took place in Germany, and you could see that each hospital has its own single cluster of Acinetobacters that are really unique and well understood. It's a one strain that causes an outbreak per hospital. However, from our previous work that you could see here in this figure, these are samples that we collected from Libya during the conflict that was going on. You could see that there is more of a chaotic distribution of the strains and the sequence types that actually were collected from 3 different hospitals, 2 in Tripoli and 1 in Benghazi. However, you can see quite clearly from the color coded from the color codes over here that these samples, they form various clusters within the same hospital. So usually what you would observe in conflict is chaos and no longer nosocomial outbreak caused by a single strain. Additionally, usually what we have in Lebanon and what we have circulating, and this is from a very recent publication that we, together with Dr. Kanj and other folks at the Infectious Diseases Department at AUB, worked on. You could see that usually the outbreaks cluster, as we mentioned previously, and there would be very few samples here in pink. These would be travel associated that we can very easily identify because they don't cluster with those samples very well. However, when we start looking at the samples in conflict versus samples outside conflict era or outside the conflict window, you would start having quite a lot of differences in sequence types, in distributions, and in the presence of antimicrobial resistance genes. Now, why is this important? This is important because usually what you observe with patients is something typical as to this table over here. You could see that these are the sets of antimicrobial resistance genes that are present in a typical Acinetobacter baumannii, causing a nosocomial outbreak or causing an infection in any patient in the ICU in Lebanon. This is the typical signature of these strains. Now, when we sequenced the samples that were collected during the escalation of conflict and the post-escalation of conflict, because remember, AMR and conflict are not a short-term story. It's not a short-term relationship. It's a relationship that drags and drags for years. So when we looked at those samples, we did the sequencing at first, and we thought, oh, they have very little antimicrobial resistance genes. They must be sensitive to antibiotics. Why would they be causing problems? We did the antimicrobial sensitivity profile, and they turned out to be XDR strains quite similar to the ones that circulate and cause nosocomial outbreaks. But what is very interesting for us is these set of genes, these ADEC, ADEA, ADEI, and ADEK, and I'll tell you what they mean in a very brief way. These mean that the strain that we are discussing has too many efflux pumps that are activated, making it resistant to antibiotics instead of having acquired resistance genes like a usual strain that circulates happens. Now, we do see a vast difference between those strains also when we do the broth microdilution assay to determine the level of resistance to the antibiotics. Usually you would see an MIC of 64 micrograms per ml. So the minimum inhibitory concentration of meropenem would be 64 or 32 whenever a strain has an OXA or an NDM. But when you have an efflux pump, you start talking about MICs of 512 micrograms per ml, all the way up to above 2048 micrograms per ml. So imagine you will need more than 2 grams actually to kill the bacterium. And that's because those efflux pumps are activated. Now, this is all interesting. This is all challenging, but above all, we would very much want to understand why is this happening? Why bullets and destruction are helping in creating these superbugs that make things more and more difficult to treat. And the approach that we follow is we look at heavy metals that erupt and occur from conflict, and how do they affect antimicrobial resistance, and why heavy metals specifically. In a nutshell, pre-antibiotic era, heavy metals were used to actually treat infections, right? And up till today, copper, for instance, is still used in quite a lot of the instruments and in the OR as an antibacterial coat. However, when heavy metals start affecting bacteria, we start looking at things called cross resistance, and it's when you would have one gene which causes resistance to antibiotics, it will also cause resistance to heavy metals, or vice versa. You, like an efflux pump, you would have something called co-resistance, where two genes would coexist together and would get activated together, where each gene would be responsible for a certain activity. One would be activity resistance towards antibiotic, the other one would be towards heavy metal. And the third approach is the co-regulation, where you would have one regulator that could activate two genes. One is resistance to antibiotics and one is resistance to heavy metals. Now, the two approaches that we personally are focusing on the most are 1 and 3. 1 and 3 because they both do exist when it comes to efflux pumps and to the way efflux pumps work in activating resistance to antibiotics and heavy metals at the same time. So we decided to take the next step, and we took a sensitive strain of Acinetobacter baumannii that we know of. We know that we know the genomics of this strain, and we started incubating it with heavy metals over time in the lab. And every now and then, we would assess its antibiotic sensitivity and see if we observe any change. And definitely we've seen differences and changes, especially when we look at vanadium as a heavy metal, when we looked at zinc, when we looked at lead, and when we looked at mercury. We couldn't get our hands on all of the heavy metals because quite a lot of them are actually not allowed to enter the country. But vanadium, for instance, is heavily used in artillery and in shells, in bombs, in rockets. So is lead, and so is zinc, and so is mercury as well. And these are the ones that we know of after doing some extensive research on artillery manufacturing and all of that approach. We also have taken this to the next step as well. We've collaborated with the Lebanese army. We went up, we told them our project and our story. And what they did was they actually fired some bullets into their sandbags, and they've handed us over their bullets. And what we have been doing since that day is incubating Acinetobacter baumannii, that same sensitive strain, in the presence of a bullet, right, over a very long period of time. And we've been monitoring that strain weekly. Now, what is very interesting for you to see is this would be on day one, right? And when you look at how the media and the bacterium becomes at day number 2, you could see this tinge of color from the copper and the nickel and the lead that becomes leaching out into solution. Now, after 4 or 5 days, you could see the solution turning almost copper green. And we are now in the process of analyzing why this bacterium became resistant to 4 different classes just by incubating it to actually incubating it with a bullet for a period of 2 or 3 months. Additionally, we're assessing how this helps in their biofilm formation, because we know for a fact patients who end up with shrapnels, they suffer from reoccurring infections. We know that this has not been previously investigated. Reoccurring infections, do they come from the same strain? Is it a biofilm somewhere in the body or on a shrapnel that is leaching out to the body, causing this reoccurring infection or not? These are so our work is I wouldn't say at the very early stages. We now have a very decent collection of samples that crosses the around 700 or 800 isolates from war wounded patients during conflict, during escalation. We are still collecting post-escalation, and we're very much hoping to actually be able to connect the dots and explain at the molecular level how this is happening and which efflux pumps are being activated in the case of Acinetobacter baumannii. But bear in mind, we're also looking at Pseudomonas aeruginosa, E. coli, and Klebsiella as well, because we do see this in all of those gram negatives. For the interest of time, I'm not going to talk about the rest, but I'm happy to answer any questions you guys have. At the end, I would like to thank my collaborators, and I would enormously like to thank my team who has been working relentlessly on this crazy idea of ours. And I would like to thank you for your attention.
Thank you very much, Dr. Tony Abou Fayad, for your presentation and for all the excellent work you're doing to try to understand the molecular mechanism of the multidrug-resistant Acinetobacter that we are struggling with in many infections, including in wound infections. And so I think we'll leave the questions till after the presentations. And it's now my distinct pleasure to introduce my friend and colleague, Professor Heiman Wertheim. So Professor Wertheim is a professor of clinical microbiology, and he's head of clinical microbiology at the department at the Radboud University Medical Center in Nijmegen in the Netherlands. He's the president of the Dutch Society of Medical Microbiology, and very importantly, he's the president-elect of ISAC. And so Professor Wertheim has been doing some work in Ukraine as part of the WHO collaboration that he's going to tell us about. So we invite him to share with us his talk on emergence of MDR pathogens in wounds, and this time the Ukraine experience. Heiman.
Yeah, thank you, Souha, for your kind introduction. So I'll indeed explain a little bit about the experience I had. So it's really a personal story, and so probably not fully encompassing what's happening in the Ukraine. And I think the main message is that, you know, and also from the previous speaker, Antoine, Acinetobacter and the resistance issue that we see developing during conflict. I think the best antibiotic stewardship approach is peace in that sense. So let's hope that it will happen for everybody soon. So I'll tell you a little bit. So Antoine already alluded a little bit about the resistance issue, but particularly maybe there are more dermatologists and plastic surgeons and different kinds of people. So maybe just a little bit of flavor of the international context of the AMR, but very brief. And then also some comparisons to explain why are some countries have little resistance problems and why do others have more. And this is not depending on conflict, just a general sort of, comparison. And then I'll dive into the Ukraine WHO mission experience. So generally, so for those not being microbiologists or infectious disease doctors, so antibiotic resistance, and this is, you know, a bit of a very common slide that everybody uses that talks about it. But if we don't do anything by 2050, we could have a huge problem, the same number of deaths or even more than we have due to cancer. I mean, that is sort of what we're at. So that's why the United Nations, WHO, everybody's really getting into this to make sure that we are saving these people from, you know, the burden of AMR. So that is what we are also here for, but then to prevent people with skin and soft tissue infections or orthopedic issues due to trauma and conflict. And that's why I put a square around skin in this figure. So this is a paper in quite recent from the GRAM study. So the GRAM study was led by the Oxford University group in the UK that did a huge worldwide analysis of antibiotic resistance in the world, looking, okay, what is really associated, so the burden of disease with resistance, and looking at the deaths, so the mortality, and what is really attributable. So the dark part is attributable and the lighter part is associated, and you really see for skin, it's still quite limited if you compare it, for instance, to bloodstream infections and lower respiratory tract infections and intra-abdominal infections. But of course, war wounds are not just related to skin, it's also orthopedic, and it's also intra-abdominal, and also, you know, so it's a huge complex. So you have a lot of injuries and deep penetrating wounds and a lot of normally sterile organs are really causing a big problem. So I just, because it's sort of also because of the association with skin today, I just wanted to elaborate a little bit on that. So it can be a huge problem, particularly as the injuries that we relate to wounds due to war and conflict are deeper than just skin. And if you look at the burden of disease due to antibiotic resistance, and Europe has a long history of collecting a lot of data that's now done by the European Center for Disease Control. And as you see, the lighter, the better, and the darker, not so good. In Ukraine, we don't have data yet, but there are actually a lot of initiatives also in these areas to get data and to, you know, put them on the map. But likely, if you look at the burden of disease and looking at, you know, the disability adjusted life years per 100,000 people. So the Netherlands and Northern Europe, Norway, Sweden, Finland, actually, we do actually quite well compared to the more Mediterranean countries. And likely Ukraine is really somewhere like Romania and the other Eastern European countries. So probably at the darker end, looking at the burden of disease due to antibiotic resistance. And if you look more, okay, so for other disease, so this is for methicillin-resistant Staph aureus. So if you look at the prevalence data, so this is like microbiology data that's also collected across Europe. And again, also here for MRSA, so methicillin-resistant Staph aureus. Also here, again, Northern Europe is really, so you show that little resistance, less burden due to drug-resistant infections. And again, also here, Eastern Europe, and likely Ukraine is also in the red part expectedly. So what is happening? So why are some countries red and why are some countries green? So I cannot really tell what's really always happening in red countries, but I do know because I talk to a lot to my colleagues in Denmark and in Sweden. And what you see is really that we do things quite in a similar way. And one part is that we have very little antibiotic use. And of course, we can, okay, why is that? But if you look at this is also European data, looking at antibiotic consumption in different countries. Also, again, here, you see the Northern European countries have the least antibiotic use in Europe. Potentially, Ukraine is probably more down here in the area of Romania. And if I've been in the hospitals and I've been outside and I've been able to buy over-the-counter antibiotics, so I guess indeed they will be around that area. But if I talk to my colleagues in Northern Europe, and we actually also did recently a survey of different societies across the world, how are people handling the issue of antibiotic resistance? But if you look at and talk to the professionals, actually in Northern Europe, generally it's a coherent system of healthcare in general. So there's resources, and of course, but other countries which are coloring red, they also have resources. So it's not just about resources and investment. It's also about, okay, how are you actually handling the resources in the best way? So one prerequisite, good resources, but also what do you do and having agreements, what you do on a national level. So having guidelines and really these guidelines, and generally in the countries, but in Northern Europe, they are really led by the professional societies. So really professionals are in the lead. And we have a proactive system also in procuring antibiotics, and antibiotics that we procure are in line with the guidelines. And also if we test in the microbiology lab, is also in line with guidelines. So in that sense, it's really coherent, good quality of care, and a good collaboration between the various institutes, sharing of data, sharing knowledge. And this results in the end in good antibiotic use, good infection prevention, and good surveillance. So yeah, you need this information, but the information needs to be put into action. And in general, because I'm a microbiologist, so infection prevention and good antibiotic use is nothing without good microbiology. So, and if you don't have it, microbiology, it's like driving in the dark without your lights on. As you can see in the slide, you don't see a lot. So you really need those lights and you really need that microbiology. And if you look, so we are in the Netherlands and some other European countries, so we are receiving Ukrainian soldiers with complex prosthetic surgery, that need prosthetic surgery for huge injuries, that blast injuries, and having huge defects to repair the defects, but also they come in with complex infections. And then for us in the Netherlands, we have very little carbapenem resistance. As you've seen in the previous slide, we have very little burden of resistance. So one patient, that we culture in various sites. So this is an example of one patient. So this patient at 11 for us, really resistant gram negatives, and with various carbapenemase genes, various mechanisms. And in the Netherlands in total, maybe before the Ukraine war, we had maybe totally 30 patients with 1 gram negative resistance to carbapenems. And here in one patient, we almost have like 11 different ones just within one patient. So also this really bumped up our numbers. Currently, we discussed today in our multidisciplinary meeting, we have one more case of a Ukraine soldier now in the medium care unit, also after surgery. And this patient had an Acinetobacter, carbapenem resistant, and probably important to know, we put these patients in aerogenic isolation. So Acinetobacter is known that you need to do more than other gram negatives. So other gram negatives, you can do just contact isolation, but for Acinetobacter particularly, be aware because it really can easily transport through the air. So you need different isolation measures. So if you have them, of course, if you have a high burden of disease due to Acinetobacter, of course, then it is not possible. So this is a slide, and I can briefly skip it because Antoine already alluded a bit on mechanisms. So in the Netherlands, we see various organisms very commonly, Klebsiella, E. coli, Pseudomonas, and also Acinetobacter, but Acinetobacter bit less compared to Pseudomonas and so the Enterobacterales, like E. coli, Klebsiella. These are the most common ones that we see. And if you look at sort of the history of Ukraine, so I'm now going to go slowly more into the mission in the Ukraine in the last 10 minutes. So this is already what I had. So I reading also the literature a bit about it. And they had another conflict in 2014 when the Crimea was taken by Russia, so all the way in the east. And now in the recent year, there was, of course, the Eastern Ukraine invasion. And they looked at 125 patients in the whole time from 2014. So the first, actually the start of the war up to quite more recently. And you see actually also the gram negatives and particularly high resistance to carbapenems. And actually in Klebsiella pneumoniae, you see a huge jump over time. from 29% to 90% carbapenem resistance. So also here you see huge changes, and actually the numbers for Pseudomonas and Klebsiella should actually be the other way around. So apologies. Then if you go down to Ukraine, so that is, so what kind of country is it, and how can we compare it to Lebanon, for instance? So 35 million people. So it's like double the Netherlands. So we have like 19 million in the Netherlands. And Lebanon fits 58 times in Ukraine. It's a huge country. The Netherlands will fit about 15 times into the Ukraine, mainly Christian religion, economically mainly based on agriculture and industry. Now, as we understand Donald Trump, they also have interesting stuff for mines. So probably we'll hear more about it soon. 70% lives urban. Netherlands is like 90% urbanized. And if you compare, like, okay, how does it economically work for a household? So 40% of their income goes to food. And in the Netherlands, about 10% of your income will go to food, of course, depending on your income level and what kind of food you like. And importantly, 50% is out of pocket for health expense, but not for the soldiers. They are fully covered in general by insurance and by the military. So the country's at war, as I told, and there's no air travel possible at all. And if you look at the demographics, it's quite a middle-aged sort of population. But of course, here you already will see, and of course, in other countries, you also see the same, unfortunately, that particularly in the male side, you'll get a decrease in this end. And it will also mean something for your reproduction later on and having children. So you probably will see a decrease, particularly in the blue part, but in the end, also the offspring will be different because, yeah, there's less men, for starting families, which is, of course, a very sad story. So for the mission for WHO, as we saw already in the Netherlands, but also they experienced it locally. That's why people ask, hey, you're going to Ukraine, is that useful? But they're really struggling with the drug-resistant infections. They don't know how to treat it. They see failures. And of course, because of the soldiers, they see huge problems with it. So there was a huge motivation to do something about it. So this WHO mission came along for that. So this was really to analyze the infection care chain. So looking at diagnostics, looking at prevention, looking at treatment in Dnipro region. So Dnipro is all the way in the east, about 150 kilometers away from the front line. So 2 hospitals we analyzed there, but we also had a regional meeting with other hospitals. So to have a learning environment. And the idea was to go 3 weeks. So not just having like a quick coming in and tell them, I see this and do this, but really having interventions on the spot, implementing with them, looking at the troubles, following up, and also come with a report for the recommendations. So it's really like on the spot doing your interventions there. So I'm from the Netherlands, so you cannot fly. So I had to fly from Amsterdam to Warsaw, from Warsaw. So it was quite a long trip all the way to here to Dnipro, which is right over here. Here is Zaporizhia. And this was on my way back, which was a bit closer. So this next time I will go to Moldova rather than through Warsaw. And of course, yeah, many people here on the call will probably know this, but for me, from being from the Netherlands, this was really quite new to have, having air alert systems and apps installed on your phone, which are actually going off all the time, particularly at night. So you can also imagine for the people there and working in the hospitals, having very little sleep. It's quite, and for them it's being for years. For me, it was just a few weeks. It's, can be quite, putting a stress on you. So these are the hospitals, and this is the team. So here's myself, and this is Arkady from the WHO. He's a pediatrician. This is Eugene, also WHO consultant, who was like the translator, and Alona, social scientist, looking at sort of the social aspects. So this is the Dnipro hospitals. So this is a general hospital, 1,000 beds, and this is really an infection-specific hospital that we included in this mission. And the interesting thing is, and I don't know really the situation that you all have been, but actually the labs, generally there are investments and is modern stuff. So these are like resources, yeah, but the resources differ. So this is one lab with an automated backed blood culture system, and this is the other lab, which is still handmade. And here you see that after this, they introduced this, the blood culture requests really went up hugely because they see the quality, enhanced. And here you see very little demand for these cultures. What you also see, if you look at their system, that's a huge administrative burden. So to understand one patient, what happened diagnostically, I had to go through various logbooks to really fully understand this patient. So this is really also quite, to learn, to have data that can help you understand what's going on. This, needs a bit of change. And then because there were two different labs, but they're on the same administration. So one of the recommendations is to make it a merger, to merge it to one lab. So we immediately on the spot discussed the plans. And actually, I will go back actually next week to Nipro. And the renovation is actually done by now. So I'm really curious to see what happened and how they managed. And also administratively is now a separate department and separate from clinical chemistry. But if you look at their details of the lab reports, I will not dive into detail, but actually they were very difficult for doctors to understand. And there were drugs on there that they actually could not use. So actually, so I saw one patient with a deep Staph aureus infection, also related to a wound infection, which was actually fully susceptible, so not medicine resistant, but they were treating with a reserve antibiotic. I said, why don't you use cefazolin or flucloxacillin? And they said, well, it doesn't say on the report. And I said, yes, it says here cefoxitin. And they said, well, we don't know what cefoxitin is. So I had to explain also to the lab, they need to report in a way that doctors understand. So translate cefoxitin susceptibility to flucloxacillin and cefazolin susceptibility, because these are drugs that they potentially do have access to. So observations for microbiology, and I'll go to infection prevention and also to treatment. So many logbooks, a lot of administration. They were very busy with that. In the end, they do use UCAS, so it's a good system to test for resistance, but it was not fully implemented. Like I showed with the cefoxitin issue, not translating that to cefazolin susceptibility, which is actually recommended by UCAS. And then for wounds and abscesses, they use a lot of swabs, but they don't send in pus, for instance. I don't know in your region what you do. But generally, pus is actually very useful because you can do also more testing and gram staining on it, which you cannot always do with the swabs. Also interesting that Staphylococcus epidermidis was reported from the wounds, which is generally considered commensal and skin flora and not something causing disease. And resistance results were not in line with the available antibiotics, as I already mentioned. And also, interestingly, that there was no way, so these soldiers come in with their wounds and they're quickly transferred because, they need to, a new batch of soldiers with wounds are coming in quite quickly, within 3 days. So people have to be transferred. And actually, as you can imagine, with results from culture, they take a few days and often the patient's already gone. And there's no way that they can inform the other hospital about the drug-resistant results from that patient if it's positive. So which is quite unfortunate because you lose information on the way. So this also needs improvement. So wound culture, so we prefer, and that's really have like pus and deep biopsies or needle aspirations. But this, of course, is more invasive. Swab culture is, of course, very convenient, but often very superficial. So it's really about convenience of the patient and the healthcare worker versus really be able to differentiate between colonization and infection. So this is quite important also for this meeting to really grasp that concept, particularly also looking at the pathogen, like hemolytic streptococci, like group A strep, Staph aureus, Pseudomonas, really common, known pathogens for wounds, but Acinetobacter baumannii, for instance, now also more important, particularly as Antoine already explained. So this probably in your situation with metal, probably it should go up. But the coagulase negative staph, that's only important if there's like a prosthetic device below in the wound. Looking at the therapy, so what we did is to really focus on guidelines. So what we saw, there are actually guidelines, they were there, but people didn't know or were not aware of them. So we made them aware, and I trained Julia, a pharmacy assistant, to really looking at sort of the request for reserve antibiotics, to really look at the guideline and then start to reject the authorization request. So before they were actually authorizing everything, so everything was approved. And with me, we started to disapprove, which was quite new for them. But by doing that, we also went to the wards to explain why we did that. And then they started to use the guidelines. And actually for them, it was easier because in the guidelines, there were a lot of options for non-reserve antibiotics. And actually was said, if you use a non-reserve choice, you don't need to fill in the form. So they liked that actually, and that was a huge motivation. And that way we're able to bring down, for instance, 30% of the reserve antibiotic requests and the use. So that was actually quite a quick success. I have to skip the details because of the time. So infection prevention, also here, we implemented the protocol to isolate patients with carbapenem resistance, because there were no isolation measures in place, so contact isolation, and we also checked for their UVC if it was working or not. Actually, they were. And we trained all the departments how they could isolate the patients testing positive for instance, carbapenem resistance. So to conclude, we found a lot of gaps in the system. So it was actually quite incoherent. So your guideline needs to be in line with your, antibiotic procurement, needs to be in line with your microbiological testing, should be coherent, and needs oversight. We implemented isolation measures, which was also, approved by the director of the hospital, and so a protocol was implemented. So we were, part of having a lab merger and the lab design, which was quite nice, and it became a separate department. Advise on the full UCAS implementation, not fully yet, so that's why I'm going back to be able to advise on that more, and also on the therapy end. So we had the assistant trained, and we were able to have a 30% reduction in the reserve antibiotic use and request, and we had the lessons learned, and we invited all other hospitals at one place and discussed the findings, which was really highly appreciated, and we'll do that again when I'm back next week. So this is my last slide. So thank you all. Jakayu, as they say, and this is how you spell it. So don't try. You can try it at home. So thank you, and I will stop sharing right now. So thank you, Souha. Over to you.
Thank you very much, Heiman, for sharing your impressive work in really making an impact on stewardship and AMR in Ukraine. We have attendees from Ukraine, and we've received few comments. They're really appreciating that you're sharing your experience and knowledge. Thank you. So we're gonna proceed with the next talk, and then we're gonna take the questions at the end of the webinar. And it's now my real distinct pleasure to introduce Professor Amir Ibrahim, who is the Associate Professor of Plastic Surgery, and he's currently the head of the Division of Plastic Surgery at the American University of Beirut Medical Center. And Dr. Ibrahim really had the firsthand experience in the management of the wounded patients from Lebanon in the most recent war, and had sleepless nights to save lives. So over to you, Dr. Ibrahim.
Sorry. Thank you, Dr. Kanj, for this kind invitation and introduction. And this is an amazing webinar that's shedding light on very important aspect in the management of war wounds. So I'm going to be talking about a different perspective from the surgical standpoint, what are the mechanisms of injury that can lead to infections, how we can try to prevent, and how do we think in terms of treatment. Unfortunately, we're still living in conflict zones where every now and then we're having new wars, and every time we hope this is the last war, but in a couple of years, another war starts again. And with the evolution of these wars, the weaponry is becoming more and more devastating and more destructing, and causing more civilian injuries. And indeed, nowadays, civilian injuries are the mostly affected people by those wars. Civilians, usually in the World War I, it used to account about 5 to 20%. Second World War, about 50%. Nowadays, about 80%. Some of those injured peoples are regular people, and others are journalists who work in the field, or even healthcare personnel. War-related injuries, it remains a main challenge for us, especially in a combat milieu where you have low or high intensity warfare. And why is this difficult? Because initial resuscitation is rarely feasible for those patients, because their evacuation out of an austere environment is difficult. And also in a combat setting, the tactical situation, logistical limitations, and limited availability of healthcare personnel will lead to increased mortality and morbidity incidents. Now, the situation usually it's always tailored to the ground, and the initial period is the resuscitative phase. So it is the critical period when the patient, they really need that healthcare support. So ideally, the first stage of medical aid is usually done at a field hospital. It could be airway protection, hemorrhage control, initial volume resuscitation, followed by second stage of specialized medical care or tertiary centers. This is affected a lot in limb reconstruction, especially if you have ischemic limb and you have prolonged ischemia time. This will affect to a greater extent the viability of that limb, the salvage of that limb, and the risk of infections in those limbs, and therefore the complexity of the reconstruction. War-related injuries, the severity of those injuries, it depends a lot on the intensity of the insulting energy, whether rockets, artillery shells, mortar bombs, mines, what are the body-affected areas, and if there are associated injuries such as burns or inhalation injuries. Now, in terms of mechanism of injury, from the Open Iraqi Freedom, we know that the mostly affected insulting injuries are from improvised explosive devices, from gunshot wounds, shrapnels, grenades, mortars, and in Lebanon, we have landmines a lot, even outside the period of conflicts. Now, the mechanism of injury, it could be a direct penetrating injury, such as this patient, a bullet. This is from the attack at the US Embassy recently. It could be a shrapnel. It could be even a pager, what we had several months ago. It could be also a direct non-penetrating injury. This could be from a crush injury or even just a blast injury. For example, this patient is the same patient who had a blowout fracture. So he came to us with bilateral lower extremity injury, but he had also bilateral raccoon eyes. So we did the CT scan and he had fractures of the orbital floors just from the shock wave, from the high pressure of the shock wave. It could be also thermal injury. We know that napalm, unfortunately, is still being used in those conflicts. And finally, the white phosphorus and the chemical warfare, which is extremely devastating to the soft tissues, that keeps on insulting those soft tissues for a few days until it demarcates itself, creating fourth degree chemical burn. Now, what's most peculiar about war injuries is the blast injury. So a blast was described by Theodore Benzinger. It is a shot without a bullet or a slash without a sword. It is considered everywhere within its range. So there's no only one certain area of the whole body that's affected. It's the whole body that's affected because of the blast. And this will show you at a slow motion how this shock wave progresses and how the amount of injury that can create. So when a bomb blasts, there's a chain of events with energies with extremely high pressures and temperatures. And this could lead to a direct exposure to the blast wave, reflective blast waves, acceleration, deceleration force, like you saw this patient over here. The deceleration force, there's a peak overpressure and then suddenly subatmospheric pressure. The subatmospheric pressure saved this patient because the negative pressure sucked her back, avoiding her to fall off from the balcony. Penetrating and non-penetrating wounds can occur, burns, inhalation injuries, and building collapses as well. Now, when a blast occurs, there's a shock front or a blast wind that pushes shrapnel, sand, soil, and other particles against shredded and cleaved soft tissue wounds and exposed fractures. And those shrapnels and soil and particles, they go and penetrate deep into those tissues, and it's really hard to get rid of them completely. And they are, as Dr. Antoine said, if it's bullet material, this can lead to infections and multidrug-resistant bacteria. And also, the blast front can lead to a high temperature, especially with explosive gases that can reach up to 3,000 degrees Celsius. This is another patient, head and neck area, upper extremity, torso, lower extremities, crush injury, leg over here, open fracture, femur open fracture on the other side, bilateral hands. You can see the amount of shrapnels and tiny little particles that you cannot remove completely. And definitely that patient is at high risk of developing infections. So now, war wounds, why are they different? They are different because they are heavily contaminated. These are pictures of the same patient, the journalist that I showed you before. This is one leg, this is the other leg, and also her upper extremities were affected. Those wounds, they have extensive composite soft tissue damage, devitalized tissues, foreign body loading material, and usually those patients, they present to us late, beyond what we call in plastic surgery the golden period, where it's the most important period where you can do reconstruction with lower risk of failure and infections. Now, the type of blast injury could be primary blast injury where you have direct effect to the blast, could be secondary blast injury where you have flying object due to the blast, tertiary blast injury where the whole body is displaced as a whole, and quaternary blast injury where the other effects of blast, burns, and chemical contamination. What causes infections in those war wounds? First, the devitalized tissue, as we said before, the type of wound and its severity, the foreign body loading, if they are clotting, if we have vascular injury, if there are fluid collections, heavy bacterial contamination of the wound, especially if there is soil involved and sand, adequacy of the initial debridement, and we're going to talk about it later, immediate wound care, delays in any definitive surgical care, especially if there's ischemia time, and the presence of nosocomial pathogens and unusual bacteria that could exist in the soil, such as mucormycosis. Definitely, the data have shown that prognosis for non-infected patients has much better functional outcome followed by surgical reconstruction of lower limb injuries compared to infected patients. Now, the data have shown also, as you mentioned before in your lectures about the multidrug-resistant bacteria, but we have seen also fungi and candida and mucormycosis. And the infection rate, it can vary between 5 to 70% with acute and chronic osteomyelitis. Now, if we're gonna distribute the body into different regions, we're gonna start with the head and neck region or the craniofacial region. Now, the general principles is to do a thorough but conservative repeated surgical debridement. So we try to, as much as we can, to preserve as much mucosa and soft tissue because that's very important for the reconstruction. We try to minimize the use of hardware because most of those patients, they have some extrusion of the hardware like here, like here, like here. And bone stabilization is very important. If you don't stabilize the bone, this will lead to infections and osteomyelitis. Use of external fixation is very important, or maxillomandibular fixation, or K-wires or interdental wires. Also, you can improvise and use an external fixator if you don't have the facility to use the fancy one. If you have bone loss, and you do just reconstruction with hardware, this will lead to early fistulas, plate exposure, like you see in this patient, and poor postoperative feeding. If you reconstruct that bone with just non-vascularized bone, with like bone grafts, then the risk of complication can vary between 20 to 40%. So we always try, if the bone gap is less than 4 centimeters, to use if the bone gap is more than 4 centimeters, to use vascularized bone. We never underestimate the soft tissue coverage. Even if you put a good prosthesis for reconstruction of the bone, if you don't have soft tissue coverage, this will fail. Then in that case, a flap is the option. This is the patient that I showed you before, the gunshot injury. He was one of the security at the US Embassy, got shot in the face. Left eye was completely gone, proximal half of the nose, opened the left maxillary sinus, the frontal sinus, extensive and complex soft tissue loss. And here the reconstruction, you have to, first step is to provide soft tissue coverage, close that wound as early as possible before he goes into the subacute phase where you have more inflammation and higher risk of infection. This is after 4 days from the injury. We took a big flap. Part of the muscle was put in the sinus. Here we used some hardware, but this hardware was wrapped with vascularized tissue to protect it from infection. So you can use hardware, but you have to provide good soft tissue coverage. And this is after closure. This is him after reconstruction. Now here we put a tissue expander just to resurface the nose to make it look a more natural nose, and he's still in the phase of treatment. This is another young lady, came to us in the subacute phase, completely lost left eye, and she has open orbit wound. This was reconstructed. This could have been reconstructed with a skin graft, but the skin graft is not the ideal for an ocular prosthesis, so we did a radial forearm flap for her. This is an Iraqi lady. She came to us. She had mandibular segmental loss. All those patients are war injuries. You can see the plate, how it's exposed, reconstructed with an old flap, everything contracted. So we had to take everything down, remove the plate, put some vascularized bone. This is a fibular bone. This is the peroneal vessel. And we transplant everything to the neck. And this is her after completed the reconstruction. Another young Yemeni guy, he had chronic osteomyelitis of the mandible. Here, this is a fibrous union of the bone, and he was reconstructed with a plate only. So the plate was removed because he had a sinus over here, a draining sinus with a chronic osteomyelitis. So the hardware was removed, treated for osteomyelitis, then came back. We recreated the defect. We put a fibula flap, vascularized bone with some healthy skin, and everything was reconstructed. You can see how his chin was under projected, now it's normal projection. And now he's due for osseointegrated implants, dental implants. In the extremity trauma, also from the data, the lower extremity is mostly affected, especially the leg, followed by the femur and the foot, and then followed by the upper extremity. Now, in the upper extremity, I will show you a typical example how we think of an infected wound. This Iraqi guy, soldier, he came to us with a foul-smelling, open, infected wound with the proximal half of the humerus completely lost. Okay, so in that case, you could do immediate reconstruction of bone and soft tissue, but because of the active infection in the subacute phase, then you have to debride. Try to convert this wound from a subacute to a chronic wound, a clean wound, in order to do the bony reconstruction. Otherwise, you run the risk of having osteomyelitis in the bony reconstruction. So this is after debridement, closure with skin graft. We brought him back after 3 months, and then we did a cleaning the non-vascularized bone. This is reconstructed with a free fibula over here, fixed with minimal hardware. And you can see over here how the fibula, it became big, hypertrophied, as similar to the humerus. In the lower extremity blast injury, the debate is whether to do a salvage or an amputation. Unfortunately, none of the scoring tools have included blast victims about lower extremity trauma. So key decision require clinical judgment for every patient to decide whether to do an amputation or salvage that limb. This is our journalist before. One of the limb was salvaged. The other limb had mucormycosis. We had to do an amputation for her. So for the timing of reconstruction, could be in the acute phase, subacute phase, or the chronic phase. Now, the acute phase is the ideal for us. It's called the golden period, but it's rarely feasible because of the cardiovascular instability of the patients, logistics difficulty, coagulopathies and vascular damage, and sometimes free flaps in the setup of war is really difficult because of the affected hospitals as well. All the data have shown that reconstruction in the acute phase is the best within 5 to 7 days. However, because of the difficulties to receive those patients, also recent data is showing that reconstruction in the subacute phase sometimes can be safe, but it's more challenging because of the edema and the inflammation. Now, we are talking about also nowadays about the grace period. So with the new tools of the negative pressure wound therapy, it can buy you some time in order to stabilize a wound, stabilize the patient, make the wound clean in order for a better reconstruction in the subacute phase, like the negative pressure wound therapy, but also some artificial skin or dermal substitute where you can cover the wound with artificial skin and buy some time for the patient in order to recover from her injuries and do the later reconstruction later on. For example, this patient, she had a free flap over here to cover her fractured bone. And we could not do another free flap at the same time to cover her stump over here. So we put this dermis substitute and the skin graft and brought her back after 3 months for the final reconstruction and do reconstruction of her stump. At our hospital, until 2019, we had 15 patients. Most of them were in subacute and the chronic phase, either contaminated or infected wounds. Most of those wounds were complex composite defects, bone, soft tissue, muscle, skin, tendons, etc. So in those cases, sometimes we don't go by the reconstructive ladder step by step from the simplest to the most complex. Sometimes we use what we call the reconstructive elevator, and we go all the way up to the most complex type of reconstruction in order to achieve a better functional outcome. So always we initial assess, there's initial wound assessment, operative debridement, stabilization of the bone, revascularization if needed, assess the soft tissue and the possible need for fasciotomy, wound desiccation prevention, and the use of negative pressure wound therapy. We do a second look after 24 to 48 hours, and then if possible, we do the closure within 5 to 7 days. If not, we go to further delay. We always like to replace bone with bone, like with like, soft tissue with soft tissue, skin with skin. So this is a few cases, and I'm done. A young lady, 19 years old, crush injury to her leg. She came with a subacute phase, infected wound. This patient has a complex wound, soft tissue, and bone loss from the tibia and the fibula. So ideally, if you want to go by the book, this patient is a candidate for amputation, but she was 19 years old, completely refused. So I gave her the option to close the wound by clean it up, put skin grafts on, and buy her some time. She came after 3 months, convinced that she needs amputation. So here we looked at the spare part. This foot skin is good. So we skeletonized the bone. We took the whole foot as a free tissue transfer and transplanted to the stump in order to get her a below knee amputation stump for a better fitting prosthesis. And this is a sensate free flap, so she can feel the sensation of the sole of the foot in that area. Another Iraqi general composite defect of the distal leg. This is where we call the no man's land. This is a reconstruction with of the bone for 8 centimeter gap of the tibia and the muscle, the flexor hallucis longus, and 2 skin pads, and this is him after 8 months healed. You can see how the fibular graft, how it hypertrophies and becomes as thick as the tibia. Finally, a young Lebanese soldier, she had a complex, she presented with subacute phase infected complex composite defect of her leg, 14 centimeters defect of the tibia. This is a fibular flap with some FHL bone and soleus and with a skin paddle, all in one block, and we transplant them to cover that defect. And this is her after 12 months standing on that leg. Thank you.
Thank you very much, Dr. Ibrahim, for your excellent presentation, and really heartbreaking to see the images, but at the same time, really heartwarming to see the impact you have on salvaging these patients and restoring some of their really good tissues after the devastating wounds. So I will move to the next presentation, and we will keep the questions till the end. It's now also my pleasure to introduce my colleague, Dr. Jihane Abou Rahal. Dr. Abou Rahal is Assistant Professor of Clinical and Procedural Dermatology at the American University of Beirut Medical Center. She will talk to us about management of wound scars, advancements, and treatments. And as you see, we have the electricity still getting cut off in Beirut, so that's why you see my image dark. Jihane, go ahead, please.
Good evening, and thank you for this invitation to speak in this very interesting webinar. Are you able to see my presentation?
Yes.
So I'm going to be talking about management of wounds. And the first thing, a lot of doctors who don't deal with wounds and scars, and patients as well, ask us is there any scarless wounds? Unfortunately, the scar is the normal consequence of wound healing. And biologically, there is no thing as a scarless wound once the injury has reached the dermis. The dermis is the second layer of the skin, and the epidermis, or the outer layer of the skin, is so thin that it really represents just the thickness of a paper. So once we've gone beyond that and we've reached that part of the skin or the dermis, this injury will always lead us to get a scar. So since there are no scarless wounds, how can we actually manage wounds and scars? What we do is that we work on creating the least visible scar. So we want our scar to look as much as possible like normal skin. What makes scars visible? If you compare the two pictures, the first difference you can see is that in normal skin, the pink lines that you're seeing in the dermis are the collagen fibers. And in the normal skin, these collagen fibers are usually randomly oriented to each other, which allows the skin to move in all directions in a pliable way. When we have an injury and that heals with a scar, the new tissue that is formed, the scar, will have collagen fibers that are oriented in a single direction, usually parallel to each other. So that makes a tissue that's different from the normal skin. More importantly, we also lose a lot of the epithelial appendages of our skin, which are the hair, the sebaceous gland, the erector pili muscles that are in the dermis. When the scar takes all of the dermis, it will eat these appendages out and we will end up losing them. So we'll have a different type of skin, a different texture to the skin, and a different visible look to it. So whenever we have a fresh wound, if we let it go into the pathological wound healing phase, we will get a big scar and the loss of these appendageal structures. So it's very important as much as possible to try to regenerate the skin while maintaining the hair follicles and while decreasing the area of the scar as much as possible. That is how a scar looks at a microscopic level. However, when we go further away, the scars can look and behave very differently. And this is because of several factors, the main one being difference in genetics, but also difference in the location of the wound itself. So the difference can be, first of all, in the thickness of the wound. And that even itself can have different implications. In the central picture, on the hand, you can see a wound that's thicker. This is a hypertrophic scar. A hypertrophic scar is a thick wound, but that still remains confined to the area of the original injury. On the other hand, the picture before represents a keloid. And in this, you have a thicker scar, but also a scar that keeps on extending beyond the initial injury. So it kind of is a tumor that is alive. And in this case, it's very important to try to suppress this evolution by injecting steroids. You have a different way of getting thick wounds, and these are in the lower pictures you see. These are called contractures. In these type of wounds, because the scar heals in a way that often contracts the skin of the scar away from the normal skin, whenever we have an injury that's going to go into an area that's supposed to be concave, this retraction will cause a contracture that you can see on the hand of this kid, for instance. You can also have scars that are atrophic or going towards the inside of the skin, as you can see in the other two pictures. And often these happen if there's a lot of tension applied on a specific area while the wound is still generating collagen, and you get then a stretching of the skin because it does not have yet provided, scar has not yet grown enough collagen for it to be strong enough and resist that stretching element. So when we talk about thick versus depressed scar, this would depend a lot on the amount of collagen that is formed during the wound healing process. And the wound healing process is a very long process for people who are not used to dealing with wounds. We assume that the wound healing phase is done once the skin does not look injured anymore, which would be at the end of 3 weeks. But that's only the end of the first 3 stages of the wound healing. After that, after 3 weeks, and sometimes that can take up to 6 weeks, once the skin looks completely back to normal, you still have up to a year of continuous healing under the skin where you have remodeling. And it's very important to take care of the wound healing during that period as well. When we talk about hypertrophic versus keloidal scar, even though both look very thick, a lot of different things are happening under the skin. For instance, the collagen synthesis in a keloid is 20 times higher than that of a normal skin, and it's still at least 2.5 times higher than that of a hypertrophic scar. We also have a much higher ratio of collagen 1 to collagen 2 in the skin in the keloid scar as opposed to a hypertrophic scar. Scars can also look and behave very differently based on the color they will have. So I've already talked about the thickness, the atrophy, and the keloidal part, but we can also have different colors of the scars themselves. In the first picture to the right of to the left, you can see that we have pigmentation, and that's because the skin can develop post-inflammatory hyperpigmentation, specifically if the wound is exposed to the sun early in the area of healing, even in the remodeling phase. On the other side of the screen, you can see a wound that can leave a hypopigmented area if the injury has led to a loss of melanocytes in the skin in that area. And in the center, you see an injury where you have kind of tattooing of the skin from external particle, because this is from a blast from the pager, and you can see that the material of the pager went into the skin, and you have a lot of foreign material in the skin that is also creating a different color to the skin as well. This was also, we saw a lot of these in the Beirut port blast explosion, because we had a lot of ammonia and particle that went into the wound of these patients. So scars can look very different, and it's very important to understand what type of scar we're dealing with to know how to treat them. And as I mentioned, many factors will determine a scar appearance and ultimately its treatment. This will be the degree of severity of the initial wound and how deep it went in the dermis or deeper than the dermis even, the location of the wound, as well as other factors that are more inherent to the patient himself, like the age, the sex, and the ethnicity. The darker skin will always heal with more pigmentation. Like I mentioned, the scar formation is a consequence of wound healing. But wound healing is a multi-step process that will go on for months. So it's very important to keep that in mind and to optimize wound healing whenever we want to deal with future scars. So to get optimal scars, the first step is to optimize the wound healing, and you have already won 80% of the fight you're going to be fighting. So prevention and early intervention is very important. And I'm going to go back to the example of this young kid who had a traumatic injury to her shoulder. In the first 3 weeks, in the first 2 to 3 days, we have the acute phase where we're going to have hemostasis and then inflammation, and the inflammatory cells coming to start producing the growth factor the wound needs for healing. And then from day 3 till complete healing of the epidermis, we have the proliferation phase. In that part of the wound healing, if you have an injury that's deep enough to require surgical management, we have to optimize the way we suture. And it's very important to optimize the dressing for either wounds that were surgically managed or for wounds that cannot be surgically managed and have to let heal in secondary intention. And the most important thing to keep in mind that we need to provide the proper dressing that will keep the wounds moist. We should not let the wound scab and let it dry out, because that will leave a worse eventual scar. And it's also very important to think of sun protection for early scar tissue, specifically in the first 3 months, so we avoid the hyperpigmentation. What do I mean by the proper dressing? As I mentioned, the wound should be kept moist at all time, and that means triple dressing. The first layer is an ointment, which could be an antibiotic ointment, but there's actually no need for an antibiotic ointment if we don't think the skin is infected. We can just use Vaseline or Aquaphor, and these are very thick ointment that will allow all the growth factors to remain in the wound so that we have migration of the cells, proper angiogenesis, proper epithelialization. Once the wound dries, the scab does not allow the formation of this healthy new skin that's getting to the area where it needs to go. The second layer on top of the ointment should be a non-sticky gauze. These are Bactigras, paraffin gauze, Fusigras. They're non-sticky gauze that allow the ointment to stay on the wound. And the third layer should be a dry gauze to absorb any exudate. And that should stay in place until you see this scab. You keep it beyond the scab until you reach the phase of remodeling. So once you have this type of skin is when you can stop putting your triple dressing. So at this point, you have to realize what type of scar you're forming to know how to deal with the primary phase of wound healing in the stage 3 of remodeling. So in this patient, we had a hypopigmented area, and because of that, I could allow the patient to get gradual sun exposure after the first 3 months of the wound healing. And you can notice in the center a difference in colors, a darker part. This is not pigmentation, this is red, so we have increased vasculature. And we also have a thicker part, which is the contracture of the wound, because this is an area where you have a bit of concavity, so you can get a contracture. These we can use on them topical steroid, which is what I used. If they're thicker, we can use intralesional steroid, but there was no need for that. And it's also a good idea to use silicone sheets and keep applying these silicone sheets on these areas to allow for stabilization of the area and decrease the contracture, and that's 5 to 6 months later. There are studies that have been coming out in the literature about PRP. You might be familiar with PRP, which is the platelet-rich plasma that we use a lot in dermatology for a lot of cosmetic procedures. We can use it for rejuvenation. We can use it for improved hair growth. How do we get the PRP? We usually draw the blood of the patient, then we centrifuge it to separate the RBCs from the plasma and the platelets. We take the platelet-rich plasma, then we re-inject it in the area we want it to work. And it seems that this PRP is very, very useful in wound healing because it contains copious number of growth factors and cytokines. And this will promote proliferation, differentiation, and migration of cells. Almost all cells that are needed in wound healing, from fibroblasts to epithelial cells to endothelial cells to mesenchymal stem cells. And there are a lot of studies that are showing a significant reduction in the wound size and in the time needed for wound healing. And we've had a few patients that we treated with PRP, either for chronic ulcers or for injuries, traumatic injuries, and they showed a more rapid wound healing than their patients who are not treated with PRP. Interestingly, there are even studies that have addressed the fact that PRP might have antimicrobial action. This was an animal-based study. They created a wound and they inoculated the wound with MRSA. In the PRP group, they only injected PRP at a week interval. And the other group, they applied topical clindamycin. And you can see that the PRP group showed a much faster improvement in the wound, which is obviously also associated with the antimicrobial activity that was shown in the paper. So when we're managing wound, there are injectables like PRP and injectable therapies we can use, and there are other physical therapies we are using. In the injectable therapies, it's very well known, and it's been known for a long time that intralesional steroids are an amazing tool to use when we have keloid or hypertrophic scars. It's a first-line therapy for these with very good results, but often we use a monthly injection regimen, and it can be diluted based on need. In the refractory cases, we can add either 5-FU or bleomycin. And I had a patient who received the 5-FU injection for a scar on the face post-blast injury that had a very severe retraction downward with a good result on the 5-FU. Something that's less known is that injecting Botox in the areas where the scars are can help us get better scars. There are a lot of literature. This started with cleft lip and reconstruction in kids, and they noticed that then when they inject Botox in this area, specifically in the first few months, because of less movement in the area, you have less tension on the wound. A fresh wound and a fresh scar, when we have the remodeling phase, we need up to 2 to 3 months to reach an 80% strength in the scar as compared to normal skin. So when we remove sutures at 2 weeks, for instance, the scar at that time has only 20% strength compared to normal skin. So any stretch on it from normal movement can widen the scar. You can see in this picture that within the same patient, the lower area was injected with Botox, and because of less stretching, the patient ended up having a thinner scar as opposed to the upper part. So that's good to keep in mind as well. It's very important to note that sometimes going for a surgical scar revision is important before going to other modalities, specifically if the initial repair was done in the wrong direction, or if the wound was in the wrong direction. Like I mentioned, any flexural areas in this case, you can see the contracture of the wound. And the best way to treat these is to change the whole direction of the scar. We do Z-plasties or sequential Z-plasties, and this will change the tension on the scar. And even though initially it might look uglier, the fact that these are in less tense areas mean that the scar will look much nicer down the line. Another indication for surgical scar revision is scars that are very wide because they were sutured, sometimes without deep suture because there was no time. Reoperating will give us better results if we suture in a better technique. We come to laser-based therapies, which I think are the most important new techniques we've had, and these have changed completely the way we deal with scars. It's a revolution in how much we can improve scars we have, and they will work for all types of scar by reducing the color, whether the redness from the vessels or the hyperpigmentation, and by improving the texture and the thickness of the scar itself through enhancing collagen remodeling. This is a case of a colleague, also a Beirut port blast victim, doctor from one of the hospital who had this injury to her face. And after several sessions of laser, you can see how faint the scar becomes. How do laser works? The light in the laser will target specific chromophore on the skin based on the type of laser. And this can be hemoglobin for vascular laser, or melanin, in which case we improve the pigmentation, or water and collagen, in which case you will get better scars. When it comes to scar, maybe one of the two most impressive lasers that give us good results are the fractional ablative or the non-ablative fractional laser. The difference between these is that both of these lasers will cause very small injuries to the skin. And in the ablative case, you will have vaporization of colons that will reach the dermis. And these colons will then have time to heal slowly with the creation of better collagen production. You can also do the same concept with non-ablative lasers. These will heat colons of skin, and you get thermal injuries without getting an opening through and through. Good examples are CO2 laser or erbium YAG. For ablative or non-ablative include PDL, Nd:YAG, and Fraxel. And they can help us target hypertrophic scar, colors in the scar, even atrophic scars. Fractional and ablative laser will allow us to create these small holes where you get collagen and then fill up the atrophy. This is one of my patients who was a victim of the Beirut port explosion, and you can see that she had a lot of scars in her face, but after around 5 to 6 laser session, a mix of ablative, fractional, and Nd:YAG, the scars are barely visible. The limitation and the challenges in laser treatment is that there is a risk of hyperpigmentation in darker skin. These can be a bit expensive, but a lot of time, I think a lot of us are treating the scars pro bono in an attempt to give back to the community. And there is often a need to do multiple sessions with the downtime from the stronger lasers where you have a week of proper care. So in conclusion, ideally, we should optimize wound healing to decrease the scars, but once we have scars, we have a lot of therapy we can use. Laser therapy is a cornerstone in modern scar treatment, and it's very important to know which patient to select and how to give them the post-care that's needed for optimal outcome. Thank you.
Thank you very much, Dr. Jihane Abou Rahal, for an excellent presentation and sharing your experience and personal patients and results. Really impressive, the results you're having. So we have time for a few questions. I think I'm gonna start reading some of the questions in the chat. So first question to Tony. Are you with us, Antoine?
Yes, I am.
Yeah, so there is a question about they're asking if the bullet that's entering the body is already colonized with the multidrug-resistant Acinetobacter. So is it the metallic foreign body that is the risk factor for the resistance?
Actually, that's a very good question. No, it's not the bullet entering. It's actually what happens after the bullet enters, because we know quite well these bullets fly at very high temperatures where bacteria wouldn't survive. But it's the the follow-up actions that actually take place, especially with the shrapnel as well, not only with the bullet, when there would be dirt and dust that enter the wound right after the shrapnel enters at a very high temperature.
Yeah, thank you, Tony. Question for Heiman. So Heiman, it's impressive the type of work you've been able to do in Ukraine. And the question is, would you be able to have the people you trained in Ukraine use the model of train the trainer? So you train them and then they can train other colleagues in other hospitals in Ukraine in the stewardship efforts, infection control, and the microbiology detection.
No, that's an excellent point. So what we did is have actually a regional meeting. So what we want is that the people really find each other. So train a trainer is of course an excellent idea, but so what we already find out, and this is a phenomenon with other countries also, like in Vietnam, I also noticed where I worked for 9 years. It's quite hierarchical and very difficult to organize meetings on own initiatives and so on. So in a sense, it's really about, how can you create freedom for professionals to meet and learn from each other, which is actually not really present there. So everybody's really in their own environment, which is really unfortunate. So what we're going to have is another meeting also in Lviv. More hospitals are coming, so we're going to have a learning environment. But this is really also, again, organized by WHO, and you want the, institutes, the infection control people, the surgeons, the microbiologists, whoever, to, organize themselves, and they don't have a professional society really focused in this area. So it's really also trying to see how can you make sure the professionals are organized better, that they create a learning environment. That's where it should start.
Yeah. Thank you, Heiman. So Amir, question about, so 2 quick questions. The first one is the grace period, for how long do you consider the grace period lasting in a patient when you're trying to make a decision?
Yeah, that's a great question. When we say grace is a period where it allows us to stabilize the patient medically, surgically, from all aspects to prepare the patient for a certain type of complex reconstruction. Because, you know, those surgeries, sometimes they are very long, around 10, 12 hours, sometimes even more. And you need the patient to be fit for those surgeries. I'll give you an example. Our journalist, she came to us after 10 hours of ischemia time, bilateral limbs, with a hemoglobin of 4. That was almost incompatible with life. So, and she underwent, I remember, 7 surgeries within 4 days in order to stabilize her, to salvage her limb. And then later on, we recognized that she was developing mucormycosis in the other limb. So this requires multiple procedures in terms of debridement until the wound is stable. And with the negative pressure wound therapy or the dermal substitute, which is an artificial skin, this will allow you to cover that wound temporarily, prepare it for the final reconstruction during that critical period of the patient, then when she is not fit for the final reconstruction.
Yeah,
And she does not have anything to lose. You're using artificial skin.
right, right. Thank you, Amir. Jihane, so there is a question about when do you start laser therapy in these scars? Like, so there is an injury, a scar develops, and then when is the proper time to apply your laser therapy?
We used to think that it's better to wait 6 months because the figure we quote is that at 6 months, the main part of wound healing and remodeling is done. So people used to wait to 6 months to start the laser, but now we know that the earlier we start, the better the result we get. And by earlier, I mean within the first months after the trauma. The dilemma at this point is that sometimes some wounds will heal well on their own and leave a very small scar. So if you leave them alone for 6 months, the patient will not need the repeated laser therapy and the cost of the laser procedure. But scientifically, if we can tell that this will probably leave a very visible scar, it's better to start 4 weeks within the 4 weeks after a complete healing.
Yeah. Thank you, Jihane. A question for Heiman. So what advice would you give on the role of prophylactic broad-spectrum antibiotic in the management of wound while minding risk of AMR? So this debate of wounds are getting infected with
Oh,
AMR, pathogens.
so often,
yeah.
Yes, I mean, depends on the wound and which tissues are involved, and you know, if it's really clinically evident. I mean, so we also saw that a lot of people get injuries but don't always require antibiotics. So in Ukraine, it's actually a military protocol which says just 1 day of cefazolin or longer in case of surgery, and then until 24 hours after surgery. So that's prophylaxis. So not talking about treatment of infections of a wound. But we also saw that these people get on ceftriaxone and they're just, because they're constantly transferred. So there's a huge chaos around the patient. Nobody's taking the responsibility to stop antibiotics. So, so what we did, and which was a huge intervention, is that, you know, actually your protocol says cefazolin 24 hours, you know, just stop your ceftriaxone. So that was really quite new for them, and were not always fully aware. And they thought, oh, can I actually go from ceftriaxone also to cefazolin? And we said yes. So that had a huge impact, and that really brought down one reserve antibiotic use. Ceftriaxone is actually considered reserve in Ukraine, which is not everywhere, but so it's really also about stopping, and generally, yeah, depending on the wound, but generally short can be often already enough.
Thank you, Heiman. So, Amir, a question about when you get these heavily contaminated wounds, is there a role for irrigation with antibiotics? Do you think there's a benefit, or they might damage the fresh wounds? You're muted, Amir.
Yeah, so there's actually some new data about even negative pressure wound therapy with continuous irrigation system, closed continuous irrigation system with antibiotics. And actually, it has shown that it expedites the wound healing and controls in a better way topically the antimicrobial coverage. Inside the operating room, we always use irrigation with antibiotics, sometimes with vancomycin, sometimes gentamicin, whatever is available for us. But definitely there is data, recent data about negative pressure wound therapy with continuous, and we are getting it at AUB right now, in the coming couple of months, hopefully. We in the past we used to create our own system. If you have like an open joint that's infected, we just close the wound, put the catheter inside, and to put the patient on continuous irrigation like we do in human or animal bites in the hand, for example. Yeah, definitely.
Thank you, Amir. Question for Tony. Antoine, so there's a question by Ibrahim Ajayi on whether you checked for efflux pump activity to be sure that the detected efflux pump determinants are active. And they're saying because some genes could be silent. Tony, are you with us? Okay, I think Tony is disconnected. Amir, another question for you. Is total hip replacement indicated for delayed hip reduction in those traumatic injuries?
After the wound heals completely and at least 6 months without any history, without any documented infection and free of antibiotics, yes, it is doable. Assuming that the patient has good soft tissue coverage. If there is direct injury at that area, then in that case, we do the total hip replacement and we cover it with a healthy flap.
All right, thank you. And Jihane, is there a role for combination therapy in a scar doing Botox, laser, and PRP in a sequential way? Do you think there'll be room for improving scars on those that are very tough?
I think ideally Botox should be done just immediately after suturing or after removing the sutures, so we stabilize the area. If the wound heals relatively fast, there's no real advantage to adding PRP unless we have an open wound, and then we can start with the laser. Now, doing laser and adding on top of it PRP might even make it better, but it might add an extra cost with no studies yet to prove that the combination is ideal. It's something to keep in mind for very severe scars that are not improving on lasers alone.
All right. I think with that, I'd like to conclude.
I have one question for
Oh, yes, please.
So if you have a, let's say, chronic wound or subacute wound that it has good tissues, but it is a contaminated wound, is there any type of bacteria that predicts the reconstruction of that wound? Now, in the classical teaching in plastic surgery, if you have a colony count more than 100,000, it is a contraindicated for us to do the reconstruction. But for example, if it's streptococcus, definitely the count would be lower and we won't do the reconstruction if there's a strep inside the wound. Is there any other multidrug-resistant bacteria that can contraindicate the reconstruction of that wound due to high risk of failure in terms of reconstruction?
I mean, I think it's an excellent question. I mean, probably the honest answer is we don't know. But there's, of course, a risk, particularly if you close the wound, there's some, a bug still, you're locking it in. There generally, and particularly if there's a prosthetic device, there is a risk, and that we've seen it happening. But I can't say, this bug is more likely to do it than the other bug. And of course, and particularly if it's drug resistant and it's closed in and it's difficult, to do any sort of reoperation, and you can't treat it because it's drug resistant, then it gets quite difficult. So but often you need to take a choice, and sometimes you have to intervene and do close. So, and there will always be, if there's an open wound, there will be bacteria there. So the question is, when can you not close? Generally, with a multifaceted approach and with wise people, so generally around this case, we have a multidisciplinary team with infectious disease, surgeon, and microbiology, and we just discuss and see what's best for that patient. And
so would you recommend you mentioned about the deep tissue culture. This is what we used to do in burns. We excise, take deep tissue, and send it for culture. Would you recommend like serial culturing with negative outcome before we proceed with the
No,
reconstruction?
because I think it's very difficult to get a negative outcome, and will just stop you from doing anything which might benefit the patient. So, because there's really no evidence that is. I mean, I don't know the evidence that I have not seen it. So these are
Okay.
often very big discussions that we have. So you're doing cultures, which will probably lead to a result, and you will certainly not doing a surgery which may benefit the patient. And so I think there's room for I think some indeed bacteria could be more of a risk. But so what we generally what we do, so we make sure the wound is clean and as healthy as possible to start with, and we just do it. And we have a culture that will help us in case there is a problem later on. We know how to treat it. That is actually more or less how we do it.
Thank you.
All right. Well, I think with that, we come to the end of this webinar. I really like to thank all four speakers for their wonderful presentations. Very informative. I think we've learned a lot about these wounds of wars, and not only being complicated by multidrug-resistant bacteria, but as Dr. Ibrahim shared with us, we're seeing fungal infection, including aggressive filamentous fungal infections such as mucormycosis in these wars and wounds. And we've seen great results on really devastating wounds by the plastic surgery interventions and the dermatology cosmetic approach to wound scars. So I'd like to remind everybody that you will be receiving CME credits. If you are Lebanese, you will get CME credits for attending this webinar. This webinar will be posted on the ISAC Academy because it was endorsed by the ISAC, which is the International Society of Antimicrobial Chemotherapy. And for all those who registered and were not able to attend, they will have access to the recording of this webinar. I'm happy to say that we had 159 participants, which is a great number. And we had close to 500 registering for this webinar, which really reflects the level of interest in this topic. Again, thank you very much for our speakers. Thank you for the participants for asking your questions, and see you again in a future webinar. And again, this was a collaboration between 3 societies because we wanted really to talk about the importance of multidisciplinary approach to such problems. And thank you all and have a great evening.
Thank you.
Thank you.
Bye-bye.